Hello, everybody. It's time for a new GYN Garage. My name is Ed Pavlik, and I'm warming up here in Lexington, Kentucky as spring comes. But my colleague today is,
Frank Lawton from London, UK, and we're a little bit behind, but it's getting there. It's warmer and brighter in the mornings and slightly brighter in the evening. So, and the crocuses and the daffodils are coming up. So it's spring's on the way. In fact, I think spring actually starts in the UK in 2 days' time.
all right. Uh, we have to be sensitive to the time change now whenever that occurs because we
Oh
have
God, yes, we've had this
you,
problem before, haven't we?
so you need to let me know when it is. Um, well, Frank, I think GYN Garage today is free of tariffs, but I don't know how long that'll last. What do you think?
Yeah, yes, I think it's going to be quid pro quo, isn't it? I could, you know, Britain has survived, prospered on trade, as most other countries do, and I think for when embargoes and tariffs are put on trade, it's going to be it'll cause problems because other countries will put tariffs on and trade will stop. And let's face it, the only reason that the earth makes any money is because of selling things and buying things from people who want to sell and buy things. And I think if prices go up because of some sort of political involvement, then that's going to be an economic disaster. But then, I'm not a politician.
Well, I think we could raise money by placing a tax on, not a tax, just a usage fee on the internet, on X and on Facebook and all those things. And uh, that's sort of not been on the table.
I wonder if that's why that nice Mr. whatever he's called, Musk, happened to be there when Trump was grandstanding just to make sure that that wasn't going to happen.
That's for sure.
I think this is I know we're supposed to be talking about medicine here, but I reckon that the tax should be on thing. There should be no tax on food, vital things, reading, libraries, and clothes, because we've all got to have that. There should be a tax on a Porsche or a Bentley or a Rolls Royce. If you can afford a Rolls Royce, then the VAT or the tax should be 100%. If you can afford a Bentley, you can afford two Bentleys. Let's face it. Um, that it should be progressive. VAT or taxes shouldn't be 17% on all goods. It should be what you want. If you want to buy a spacecraft to take you to Mars, that's 1,000% tax. Oof, simple. Anyway, I'll ring your lot with all these results.
Well, today we're going to consider the question, is opportunistic self-injectomy during abdominal surgeries effective and also cost effective? Now, this question is approached by a paper that appeared in PLOS Medicine, and it's called Ovarian Cancer Prevention Through Opportunistic Self-Injectomy During Abdominal Surgery, a Cost-Effective Approach. Let's get started with you, Frank. What do you think about this paper?
Okay, well, I think in essence there is agreement that the fallopian tubes or the femoral end of the fallopian tubes are one of or is the cause the reason the pathological beginnings of ovarian cancer rather than the ovary itself. And I think there's been papers over perhaps 10 years or so suggesting this. And the idea of removing the fallopian tubes to prevent this ovarian cancer is not new. It's been suggested, particularly for patients with BRCA gene abnormalities, remove the fallopian tubes in order to reduce the risk of ovarian cancer. And this paper is a modeling analysis looking at the clinical and economic potential of doing that. And what they've done is that they have taken a group of women, well, it's a modeling thing, but they've taken a group of women who've had no salpingectomies, looking at a group and comparing them with a salpingectomy at hysterectomy or sterilization. A third group, removal of fallopian tubes at another gynecological procedure, such as endometriosis or ovarian cysts. And then a fourth group, the idea of being able to remove the fallopian tubes during abdominal surgery. And they've compared, so the no intervention is the baseline, and they've looked at. And as Ed, you've kindly put up, they've shown that the ovarian cancer prevention, if salpingectomy is carried out as hysterectomy or sterilization, is they reduce the by 5.5%, at gynecological surgery 9.8%, and abdominal surgery 15.3%. What I don't understand, since the model is supposed to take into account all of the other factors involved in these patients, why is there a difference of 5.5 versus 15% if normal looking fallopian tubes are removed at hysterectomy or at abdominal surgery? You have your gallbladder out and you remove a normal looking fallopian tube, and yet it reduces your chances, cases of ovarian cancer by 15%, whereas if it's a gynecological procedure, it's only 5%. And the figures also look at preventable deaths. So 5.6% if you have it done at hysterectomy sterilization, nearly 16% if it's done during abdominal surgery. And consequently, the lifetime risk of ovarian cancer in no salpingectomy is 1 in 80, 1 in something like that. But if you have your salpingectomy during abdominal surgery, your lifetime risk drops to 1 in 102 or 1 in 100 or so. And there's no explanation in the paper as to why this should be the case. Why has this model predicted a difference in outcome if they've tried to standardize almost everything in the 3 groups apart from what the surgery was carried out? And I'm quite concerned about that. Something doesn't ring a bell there. The other thing that you picked up on in Ed's list is that in the abstract, it's either a typographical error or it's been the proofreading is not very good. But they talk about 1,200,000 individuals in this particular study, which is 1 trillion in old money. And I think even the Empire and the Americans agree that 1,000 billion is a trillion. So I don't know where they get this figure from. Is it a typographical error, or did somebody, or did they not? Did the people who wrote the journal, wrote the article, not look at the proofs very well? Third thing is they talk about costs, and obviously they are positing the idea that if you have your fallopian tubes removed, then it's going to be a cost-saving procedure because you will not then cost the state for the money that would be needed for your having ovarian cancer, primary surgery, chemotherapy, follow-up treatment, palliative care, etc. What they don't talk about, of course, is the cost of an extra clinical appointment. You go to your gynecologist, and your gynecologist, or you go to your abdominal surgeon, and your abdominal surgeon says, "I think you ought to have your fallopian tubes removed." And you say, "Why?" "Well, we better get a gynecologist in to talk to you." Extra clinic. That's not That's not a part of the costing. Extra pathology. If you're going to remove a fallopian tube, you don't want the pathologist to say, "Yes, that's a fallopian tube." You want the pathologist to say, "There is no stick in this fallopian tube. This is not a pre-invasive fallopian abnormality." And that, if you're going to be sectioning fallopian tubes every half centimeter or whatever it is, that's an extra cost, and they don't bring that into it either. And the other thing, and I suspect if I was a German healthcare minister, I would laugh at this. The paper says if opportunistic salpingectomy is carried out in all these patients in Germany, it will save the German economy something like 10 million euros annually. And I've looked at the figures only this morning. The German healthcare budget is 489 billion euros. Saving 10 million annually is 0.0002% of the total healthcare budget for Germany. And obviously, the other thing, of course, is that should this 10 million, it will not be given to the patients who are suffering. It won't even reduce their healthcare costs. It's 10 million and it's absolutely nothing. Just to put it in, the Ukrainian war is costing Kiev 120 million euros a day. 10 million euros is nothing. So the paper is interesting. I think it has a number of flaws. I think there are a number of things that are unexplained. And I think also, to be honest, the savings are irrelevant from a healthcare point of view.
Well, I agree with you, Frank. The only point that I would raise is that their estimates of preventable ovarian cancer, fallopian tube cancer deaths maximize around 15%. And you make an assumption in listening to their presentation that they're talking about everybody should be a candidate for voluntary opportunistic self-injectomy to achieve this lowering. And what I'm really trying to say is that only about 25% of ovarian cancers, occur through disease that originates in the fallopian tube. And that's pointed out by this paper that from authors that we reviewed about 2 months ago. And that's simply to say that they were looking at the reporting of stick and how often it did occur. And then they translated that in their most recent paper to a plateauing of the detection of fallopian tube malignancy. And that was really at about 25 to 30%. So basically 75 to percent are really cancers that originate in the ovary. And that's that's the long and the short of it. So I think you can't. I think the physician who is giving counsel just can't say, well, there's a 100% chance we're going to give you a benefit. I think they have to say, well, there's a 75% chance we won't give you a benefit. That's the bottom line.
That's a very good point. I think yes, and I don't think many clinicians would support, or many patients for that matter, would support a procedure, a protocol that gave them that sort of odds. I think they'd want something a bit more hard and fast from that.
Absolutely. Well, I don't have much more to consider on this. I think this was a paper that was rich in the modeling and a lot of how they did the modeling. I think we have to admit we couldn't find or didn't understand or didn't look at, any of those three. But taking their conclusions and perhaps the way they did or didn't do things from an data input, number input standpoint, there are certain things that we had to talk about, and that's what we did. Well, very good, Frank. We're going to bring this one to a close, and
Yep.
Luckily, we'll have more warm weather to talk about next month when we talk.
I hope, looking forward to that then. Okay, we'll see you then.
Okay, bye-bye.
Bye bye now. Bye bye.